वही वहाँ पे इंटरफेरेंस हो रहा है, उसका ब्लूटूथ में बंद कर दे।
असू दे.
अबे रुक भाई.
भाई स्टार्ट करूँ. हाँ. Good afternoon to all my senior teachers and all my colleagues. Myself, Praveen Yadav, student of first MBBS from TNMC Medical College. Myself and all my colleagues, we are going to present a seminar on perforated duodenal cancer. Let's start it with a case study. We have a adult female patient uh, in general medicine. Her chief complaints are three episodes of blood vomiting and one episodes of blood stools, and she was also having pain in the epigastric area, vomiting. She also have abdominal discomfort and loss of appetite. Her past history is nil, and surgical history was also nil. uh, she has taken a mixed diet and her sleep and appetite was normal. uh, on general examination, we have his body temperature, pulse rate, blood pressure, all were normal. Her respiratory rate was little bit high, and on testing for her blood, stool, and sample of tissue for H. pylori and endoscopy, we have got her report. Now I would like my friend S. Divedi to continue.
Good afternoon, everyone. Today I'm discussing the anatomy of duodenum. Duodenum is the shortest, widest, and the most fixed part of the small intestine. It starts at the pylorus of the stomach and ends at the duodenojejunal flexure. It is 25 centimeter long and divided into four parts. First or the superior part is 2 inches. Second or the descending part is 3 inches. Third or the horizontal part is 4 inches. And fourth or the ascending part is 1 inch. Now we'll start discussing the anatomy of each part. The first part begins at the pylorus and ends at the superior duodenal flexure. The peritoneal relation includes the proximal 2.5 centimeter is mobile, whereas the distal 2.5 centimeter is fixed. The proximal part has a lesser momentum above and greater momentum below. The visceral relations include anteriorly there is quadrate lobe of the liver, gallbladder. Posteriorly there is gastroduodenal artery, bile duct, and portal vein. Superiorly, there is epiploic foramen, and inferiorly, there is head and neck of pancreas. Now, going forward to the second part. The second part has begins from the superior duodenal flexure and ends at the inferior duodenal flexure at the lower border of the third vertebra. Uh, the peritoneal relations include it is retroperitoneal, and there is peritoneum only on its anterior aspect. The visceral relations include there is right lobe of the liver, small intestine, transverse colon, transverse mesocolon. Posteriorly, there is right anterior surface of the right kidney, mainly the medial border, the right edge of the IVC, right psoas major. Now, going forward to the third part starts from the inferior duodenal flexure, and in front of the abdominal aorta. It continues at the fourth part. It starts now the peritoneal relation includes it is retroperitoneal, and the peritoneum is only present at the anterior aspect. The visceral relation includes the anteriorly there is superior mesenteric muscles and the root of mesentery. Posteriorly there is right ureter, right psoas major, IVC, abdominal aorta, which is giving an opening to the inferior mesenteric artery. Now going forward to the fourth part. In the fourth part, anteriorly there is transverse colon, transverse mesocolon, lesser sac, and stomach. Okay. Posteriorly there is left sympathetic trunk, left gonadial artery, inferior mesenteric vein, and left renal artery. Superiorly there is head, body of the pancreas. Now going forward to the ligament of Treats. It is a fibromuscular band which suspends and supports the duodenojejunal flexure. It is made up of striped muscle fibers in its upper part, elastic fibers in its middle part, smooth muscle fibers in its lower part. Its contraction causes the increase in the angle of the duodenojejunal flexure. Now going to the arterial supply. The duodenum is derived from first foregut and the midgut both. The opening of the bile duct shows the junction. The upper part of the junction is supplied by the superior pancreatico-duodenal artery, whereas the lower part is supplied by the inferior pancreatico-duodenal artery. The upper part is also supplied by the right gastric artery, gastroduodenal artery, and its retroduodenal branches, and supraduodenal artery. The first part is the commonest site for the peptic ulcer, possibly because of the direct exposure of this part to acidic contents of the stomach. The erosion of the gastroduodenal artery, which is the branch of a common hepatic artery, which is a branch of the celiac trunk, causes massive bleeding during the case of an ulcer. Now coming to the venous drainage, the most of the blood is drained to the portal vein, splenic vein, or the superior mesenteric vein. Coming to the lymphatic drainage, most of the lymph is drained into the pancreatico-duodenal nodes. From there, it goes to the hepatic nodes. Then the hepatic nodes drains into the celiac nodes and partially to the superior mesenteric nodes, which ultimately drains to the celiac cisterna chyli via the intestinal lymphatic trunk. Now, the nerve supply. The sympathetic nerve supply is mainly from the T9 and T10 spinal segments, and the parasympathetic supply is from the vagus through the celiac plexus and reach the duodenum along its arteries. Now, for further, I would like to invite Somik.
ठीक है ठीक है तेरा तेरा स्लाइड किधर है
नीचे नीचे का 20 बस बस ऊपर 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 हाँ बस बस बस
सॉरी स्टार्ट कर
Okay, so sorry for the inconvenience. Good afternoon, everyone. Further, I will be taking the macroanatomy of duodenum.
हो तो रहा है अभी क्या क्या प्रॉब्लम है तुझे हाँ क्या क्या प्रॉब्लम है
कुछ नहीं
फक दूध अभी इसको ये कैसे करूँ मैं थाम बच्चे
So good afternoon, everyone. I will be taking the macroanatomy of duodenum. So histologically, like the other layers of GIT, the layers of duodenum from inner to outer are the mucosa, the submucosa, the muscularis externa, and the serosa. In the mucosa, we can see tall, simple columnar epithelial cells with the presence of villi. In the submucosa, we can see the presence of various capillaries of venous plexus, like the mesenteric plexus. And further, in the muscularis externa, we can see inner circular layer and the outer longitudinal layer. Between the two muscle layer, we have the presence of mesenteric plexus and the outer serosa. Here we can see the presence of enterocyte, the simple columnar epithelial cells of duodenum, the intestinal crypt of Lieberkühn, Paneth cell, and the mucosa. So, the duodenum also contains the presence of villi, which are typically finger-like projections consisting of a core of reticular tissue covered by a surface epithelium. They increase the surface area of duodenum by several folds. Uh, Between the adjacent villi, we have the presence of deep pits known as the crypts of Lieberkühn. Various duodenal glands empties into these crypts. Here are some of the glands of duodenum. It is rich in Paneth cells, which has antimicrobial property, goblet cells, which secrete mucus, and the endocrine cells. So here in this slide, we can see the presence of Brunner's gland. These are the gland of duodenum. Brunner's gland help in the secretion of bicarbonate ions and the mucus. They neutralize the excess acidic content from the stomach. Further, development of duodenum. In the development of duodenum, we can see the duodenum develops from the terminal portion of foregut and the cephalic portion of midgut. But due to rotation of stomach, firstly the duodenum lies on the left side, but after the rotation of stomach, it comes to lie on the right side. So duodenum, along with the pancreas, come to lie on the right side and gets attached to the posterior abdominal wall. So therefore, duodenum is also known as secondary retroperitoneal organ. During the second month, the duodenum undergoes obliteration and then recanalization. Due to such development, the duodenum is supplied by two arteries. Firstly, the celiac artery, and secondly, the superior mesenteric artery. So, further, physiology of duodenum will be included by Yashmin.
Good morning, everyone. And now I'm going to discuss the normal physiology of duodenum. The duodenum manifests about three fundamental physiological phenomenon. First is the motility, second is the secretion, and third is the absorption. Firstly, we will discuss about motility. It consists of rhythmic segmentation, peristalsis, and peristaltic rush. The rhythmic segmentation, it means that there is local intermittent segmentation contraction which occur every few centimeters of the duodenum. Second is the peristalsis. It is a series of wave-like contraction which occur in the duodenum. It is caused by the ejection of food from the stomach into the duodenum, and it is a property of smooth muscle. Its stimulus is irritation of the duodenum or distension of the duodenum. Then third is the peristaltic rush. It means if there is any irritatory stimulus in the duodenum, then a peristaltic contraction will occur in the wall. Then secondly, we will discuss about the secretions in the duodenum. First is the mucosal secretion. It is done by the Brunner's gland which is present in the submucosa of the duodenum. It is viscous, thick and alkaline in nature. Its function is to protect the mucosa of the duodenum from the HCl secretion. Here, as we can see, the Brunner's gland, which is present in the submucosa of the duodenum. Then, second is the gastrin hormone, which is released by the G cells. When partially digested proteins are present, it will stimulate the G cells, which will further produce the gastrin hormone, which will in turn secrete histamine into the deep oxyntic cells. Here, as we can see, the G cells, uh, when get stimulated by the partially digested protein, secrete gastrin, which will in turn bind with the CCK2 receptor, which will increase the calcium level in the parietal cell and will increase the gastric HCl secretion. Second pathway is that the gastrin will stimulate the ECL cell, which will secrete histamine, which will bind with the adenylate cyclase enzyme, which will convert the ATP to cyclic AMP, which will further increase the HCl secretion. Here in the diagram, as we can, it is the diagram shows the formation of HCl. In the parietal cell, the H2 and CO2 combines to form H2CO3 with the help of an enzyme known as carbonic anhydrase. It further dissociates into H positive and bicarbonate ions. The bicarbonate ion, with the help of bicarbonate chloride co-transporter, it will go into the circulation, while the chloride ion will come into the cell and then with the help of chloride channels into the lumen of the gland. And the hydrogen ion, with the help of hydrogen potassium ATPase, that is the proton pump, it will go into the lumen of the gland and bind with the chloride ions to form HCl. Then thirdly, we will discuss about the absorption. The duodenum absorbs many substances such as water, iron, sodium, glucose, fat, and calcium. Now I'm going to invite my friend Vedant to further discuss the topic.
Good afternoon. I will introduce the topic duodenal ulcer and the disease and its epidemiology. So, the peptic ulcer occurs usually when the acid in the digestive tract eats away the internal surface, that is the mucosa of the stomach and the small intestine. They create painful opening sores that may bleed. The perforated duodenal ulcer is caused by the destruction of the mucosa of the duodenum. It occurs due to the corrosive action of the pepsin and HCl on the mucosal layer. Most perforations are on the anterior surface of the duodenum. So now the causes and symptoms. The main cause are the non-steroidal anti-inflammatory drugs like aspirin and the other prescriptional pain medications which can irritate and inflame the lining of the stomach and the intestine. And the other cause is the Helicobacter pylori. It is the bacterium which lives in the mucosa of the duodenum and the stomach, which can sometimes cause inflammation and produce an ulcer. The symptoms are upper abdominal pain, nausea, bloating, lack of appetite, weight loss, and heartburn. So now the epidemiology. In duodenal ulcer, epigastric pain arises 45 to 60 minutes after the meal or nocturnal pain relieved by food, antacid, or sometimes vomiting. The radiography or endoscopy will demonstrate ulcer in the duodenal bulb, and in 70% of the cases, it is caused because of the Helicobacter pylori bacterium, and in 20 to 30% cases, it occurs because of the non-steroidal anti-inflammatory drugs. It is a surgical emergency. It is 2 to 3 times more common than gastric ulcer perforations. So now the risk factors. These factors do not only cause the ulcer, but they can also make the ulcer worse or more difficult to cure. So the risk factors are smoking, alcohol consumption, untreated stress, eating a lot of spicy food. Now the complications which might arise if the disease is let untreated, they are the internal bleeding, hemorrhage, the perforations in the duodenal wall, obstruction, and increase in the susceptibility to gastric cancer. Thank you. Now I'd like to call Prathamesh to tell us about the pathophysiology.
Good afternoon, everyone. I will be presenting you the topic pathophysiology. Signs and symptoms of perforated duodenal ulcers are sudden and severe abdominal pain. The pain is often described as intense, sharp, and continuous. It usually begins in the upper abdomen but can spread to other area. The second one is abdominal tenderness. The abdomen becomes extremely tender to touch, and any pressure on the area worsens the pain. The next is shortness of breath. In some cases, the irritation and inflammation caused by the perforation can irritate the diaphragm, leading to difficulty in breathing. Next is nausea and vomiting. The symptom may occur due to irritation of the digestive tract and presence of stomach acid in the abdominal cavity. Next is bloating and distension. The abdomen may appear bloated and distended due to the accumulation of gases and fluid. Next is fever and chills. Infection can occur as a result of the perforation, leading to an elevation in body temperature and chills. Now, now we will be looking at the signs. First one is tachycardia and hypotension. When the content of the abdomen leak into the peritoneal cavity, it can cause a systemic inflammatory response, leading to a tachycardia and hypotension. Next is rigidity or board-like abdomen. The abdominal muscle become rigid and tense due to inflammation and irritation caused by perforation. Rebound tenderness. When pressure is applied and then suddenly released on the abdomen, there is a sharp increase in the pain, which is known as rebound tenderness. And the last one is melena. It includes black, very sticky stool, a common symptom of bleeding ulcer. It is important to note that the symptoms of perforated duodenal ulcer can be similar to other abdominal emergencies, such as appendicitis or diverticulitis. The symptoms which differentiate appendicitis and diverticulitis from perforated duodenal ulcer are: for appendicitis, it is loss of appetite, and for diverticulitis, it is change in bowel habit. Next is three phases of progress of perforated duodenal ulcer. This first one is initial phase, which start up on onset and last up to 2 hours. It includes tachycardia, epigastric pain, and cold extremities. The next is second phase, which start after two hour and last up to 12 hours. Pain become generalized and pain and increase with the movement. Fluid moving along the right pericolic gutter can lead to typical signs such as right lower quadrant tenderness and abdominal rigidity. Third phase start after 12 hours. Abdominal distension, fever, and hypotension are its characteristic. Uh, what what causes a duodenal ulcer to perforate? The main cause of the damage is infection with bacteria called Helicobacteria coli, Helicobacter pylori. The bacteria can cause the lining of your duodenum to become inflated and an ulcer can be formed. Now my friend Priyanka Tayade will continue. Thank you.
Hello, myself Priyanka Thade. We are going to discuss about the histological changes during the perforated duodenal ulcer. So here we can see that during the perforated duodenal ulcer is a further complication of the peptic ulcer. So further changes will be seen in the duodenal ulcer. First, the ulceration. As we can see here, the mucosal lining is the mucosal lining is the diminished, somewhat damaged, and the ulceration or perforated duodenal ulcer will result in the full thickness of the defect in the duodenal wall, and which leads to the damage of the epithelial lining and the underlying tissue. Acute inflammatory cells like neutrophils will infiltrate the damaged area. The granulation tissue formation. Granulation tissue composed of the new blood vessels, fibroblast, and the inflammatory cells start to develop at the margins of the ulcer, at the site of the margin ulcer, and then this will lead to the fibrosis, that is where the fibroblasts lay down the collagen fibers, and lastly the regeneration, which is to repair which repair and which will repair the ulcer site, and which aims to restore the integrity of mucosal lining. So thank you. Further will be continued by Pooja.
Good afternoon, everyone. Today I am going to present difference between duodenal ulcer and gastric ulcer. This is the image showing normal stomach and stomach having peptic ulcer. There are two types of peptic ulcer based on location: the duodenal ulcer and stomach ulcer. Peptic ulcer occurs at four sites. In duodenum, the chances of peptic ulcers are 80%. In stomach, there are chances of 19%. In duodenum and stomach, there are chances of 4%. And in mucus diverticulum, 1%. Duodenal ulcer occurs in any age, but especially between 30 to 40 years. Gastric ulcers occurs in middle age between 50 to 60 years. Uh, 80% of peptic ulcers are duodenal ulcers, and 15% of peptic ulcers are gastric ulcers. Duodenal ulcers occur more in males. Gastric ulcers occur more in females. Duodenal ulcer and gastric ulcer patients usually do stress jobs. Duodenal ulcer pain is felt in epigastric region, and gastric ulcer pain is felt in epigastric region, which can be radiated to back. Duodenal ulcer pain onset is usually 2 to 3 hours after eating, usually at midnight. Gastric ulcer pain starts immediately after eating. Duodenal ulcer pain is relieved by eating, and gastric ulcer pain starts after eating. So, duodenal ulcer is also called as Hunger's ulcer. In duodenal ulcer, vomiting is not common, but in gastric ulcer, the pain is relieved by vomiting. In duodenal ulcer, there is increased appetite. In gastric ulcer, the patient is afraid to eat. In duodenal ulcer, there is weight gain. In gastric ulcer, there is weight loss. The chances of hematomesis in duodenal ulcers are less. The chances of hematomesis in gastric ulcers are more. Melena is usually occur in duodenal ulcers, whereas chances of melena in gastric ulcers are less. Ulcer is more prone to perforate and can cause pancreatitis. The perforation of gastric ulcer is less. This is the image showing difference between gastric ulcer and duodenal ulcer. Gastric ulcer have regular, smooth, and somewhat inflamed surrounding area. Duodenal ulcer are short and elongated and have normal looking surrounding area. This is the image showing duodenal ulcer in first part of duodenum. This is the chronic ulcer. Uh, Thank you, everyone. I would like to call my colleague Akash Yadav for further presentation.
Good afternoon, everyone. The topic is investigation of duodenal ulcer. So, why it is important to investigate duodenal ulcer? It is crucial for accurate diagnosis, effective treatment, and a prevention of complications. So, diagnostic approaches, medical history. The doctor may ask the patient about any factor that may contribute to the development of ulcer, such as history of smoking or alcohol consumption or non-steroidal anti-inflammatory drugs. Physical examination, the doctor may perform a physical examination to assess the abdomen of patient for any tenderness, bloating, or abnormal masses. uh, as we know, the Helicobacter pylori is a common cause for duodenal ulcers, and blood test may help to evaluate the presence of these infections. And endoscopy, upper gastrointestinal endoscopy is a common procedure used to visualize the duodenum and identify the ulcers. In this procedure, there is a thin and flexible tube with a camera which is called as endoscope, and it is inserted into the mouth, into the digestive tract. Biopsy samples may be taken during endoscopy to test for H. pylori or other underlying causes. When there is a uh, presence of Helicobacter pylori or duodenal ulcers, biopsy may help to detect it. Urea breath test. It contains a consumable urea labeled with a radioactive or non-radioactive marker, which goes into the duodenum and digested by the uh, H. Helicobacter pylori, and it releases carbon dioxide, and this carbon dioxide can be detected into the breath. And differential diagnosis: gastric ulcer and perforated duodenal ulcer, acute appendicitis, acute cholecystitis, acute pancreatitis, renal calculi, acute intestinal obstruction. We are performing investigation to diagnose perforated duodenal ulcer from the given diseases. And imaging studies: in some cases, imaging studies like abdominal x-ray or ultrasound may be performed to rule out other conditions or complications such as perforation or obstruction. Upper gastrointestinal series, also known as barium swallow. This test involved drinking of a contrast material barium followed by X-ray to visualize the upper digestive tract, including duodenum. It can provide information about the location and size of the ulcer. So let us conclude all our points. This investigation help in confirming the diagnosis of duodenal ulcer, identifying the underlying cause such as H. pylori infection or NSAID use, and guiding appropriate treatment strategies. From now on, my friend Anupam Wane will continue.
Good afternoon. Now I'll be talking about the treatment of perforated duodenal ulcers. The treatment option and goals.
there are two lines of treatment: the medical lines of treatment and the surgical line of treatment. The medical line of treatment is generally done for stable patients, which involve histamine receptor blocker for suppressing acid production, PPI or proton inhibitors, and hydrogen ion antagonistic for decreasing acid secretion, and regular antacid for neutralization, and cytoprotective agent for protecting the mucosa. The surgical interventions in increasing order of severity goes as endoscopic repair, laparoscopic repair, surgical repair, and post-operative care. The eradication of H. pylori. This is the main treatment which is nowadays done for duodenal ulcers. The patients who are tested positive for H. pylori are given the eradication therapy. Two therapies are generally used: triple therapy and the quadruple therapy. Triple therapy includes proton pump inhibitors and two antibiotics. An example of the regimen used is omeprazole and antibiotics such as clarithromycin, metronidazole, and amoxicillin, all done twice a day. And quadruple therapy, the same regimen, but in addition, we use bismuth subsalicylate, which is a protective mucosal agent. If the recurrence is acting, we use antibiotic sensitive testing for long term acid suppression. Coming over to the management of NSAID induced ulcers, the excess NSAID use, we use the evaluate and the need for continued NSAID therapy and whether there are any alternative option. PPI co-therapy, we generally prescribe a PPI along with NSAID to reduce the risk of ulcer. Misoprostol, we use this as a prostaglandin to protect the mucosa, and COX-2 or cyclooxygenase 2 for selective COX-2 inhibitors. Coming over to palliative care support, for pain management, we use analgesic, psychological support, we do counseling, nutritional support, we consult a dietitian and form a nutritional plan, and education and support, which include providing information and counseling to the patient for the better treatment. Indication for surgical intervention. The surgical intervention is generally done for unstable or emergency care patients, which are in increasing order of their severity. First, we do the indicators are the inadequate response to the medical treatment, that is the medical treatment is not working, and the persistent symptoms after the medical therapy, that indicates that patient is not responding to the medicine. The surgical treatment, we do optimization, which includes stabilization of the patient, nutritional support if needed, smoking and alcohol moderation if needed, and antibiotic prophylaxis. Coming over to the endoscopic treatment, electrocoagulation, generally used by electric gun, and thermally active methods, a heated probe is used to stop the bleeding. Mechanical modalities, and endoscopic clip is used, and injection therapy, we inject adrenaline into the bleeding point. All of these are used to stop the bleeding. Whereas the balloon tamponade and band ligation are stopped for treating bleeding from the varices. Preoperative assessment and preparation. And coming over to the surgical treatment, we use underrunning with or without pyloroplasty, vagotomy, selective vagotomy, truncal vagotomy, or highly selective vagotomy. Truncal vagotomy is generally done with enterectomy, that is cutting a portion of antrum and joining it. Gastroduodenostomy is also done, and the cutting edge and the bleeding edge procedure for the duodenal ulcer is the Roux-en-Y gastric bypass. Zollinger-Ellison syndrome is the condition in which there is excess acid production and the tumor of duodenum, in which the surgical removal of the tumor is done. Post-treatment care and follow-up. The medication we use are continued after the treatment, such as the PPIs, proton pump inhibitor, and antibiotics. Lifestyle modification, we consult the patient for smoking, alcohol, and dietary adjustments. Follow-up and surveillance includes the follow-up visit to the physician for any other complication or regular checkup. Now I will hand over to Vishnu for the explaining the complications.
Good evening. Myself, Vishnu Murat Vishwakarma, will be explaining the complications of perforated duodenal ulcers. So we proceed. The complications are basically of five types: bleeding, perforation, gastric outlet obstruction, penetration, recurrence, and chronicity. To the right of the slide, you can see to the left of the slide, you can see the image of gastric perforated duodenal ulcer. Here you can see the formation of the granular tissue, which forms, in the much later stage when it is left untreated. So heading towards bleeding. The bleeding in the perforated duodenal ulcer occurs because of the erosion of the blood vessel. For example, if the perforation is in the first part of the duodenum, then the gastroduodenal artery is eroded, and so bleeding occurs, which also results in hematemesis, that is vomiting of the blood, and melena, that is passage of dark tarry stools, which is because of the digestion of the blood. Okay, so as you can see in the image, it is an endoscopic image of the second part of the duodenum, because the presence of the circular folds is the typical feature of the second part of the duodenum. And you can see the gastric ulcer to the posteromedial side in the image, and it's bleeding. So coming towards the perforations, it is an emergency situation, requires immediate medical intervention. Sometimes the duodenal ulcer does not get treated on time, and due to that it penetrates the wall of the duodenum, which leads to the leakage of the stomach acid and digestive enzymes and juices in the abdominal cavity, which can also result to peritonitis, which is again an emergency situation, because the peritoneum encloses and is in contact with almost all the organs: the liver, spleen, diaphragm, and other organs like transverse colon, small intestine. So if peritonitis occurs, it will affect all the organs. So it is an emergency situation, perforations of the duodenal ulcers. So in the image you can see here, the pyloric sphincter is indicated by the blue dots here, and it is an laparoscopic image showing the duodenal ulcer here. This is just another aspect of the condition taken from another angle, image, same image, but at from another angle. Third, gastric outlet obstruction. In this, when the duodenal ulcer is close to the pyloric end of the stomach, the inflammation and the swelling which occurs due to the duodenal ulcer uh, increases and obstruct the pyloric part of the stomach, which results in gastric outlet obstruction. And the symptoms of these are persistent nausea, vomiting, bloating, and inability to tolerate food. Okay, so heading towards the next, penetration. In this, the duodenal ulcer, after the digestion of the duodenal wall, the gastric secretions or the acidic secretions damage the adjoining organ which is present. For example, if the perforation is in the first part of the duodenum, it can affect the head of the pancreas also. And superiorly, if we see the epibloic foramen, after that the quadrate lobe of the liver is there. So if it is perforation is there in the upper wall of the duodenum, it can affect the liver, quadrate lobe of the liver. If it is there on the second part, it can affect the head of the pancreas. So it happens when it is left untreated for a long time. This can cause localized inflammation and can lead to serious complications such as pancreatitis, liver abscesses. It can even affect gallbladder also. Coming towards recurrence and chronicity, duodenal ulcers often have a tendency to recur even after successful treatment. For example, in the selective vagotomy, we cut the vagus nerve selectively, which supplies the organ, the lateral nerve, which supplies the stomach. But in the selective vagotomy also, the culprit nerve of the stomach is left behind. It's not cutted. So that can also lead to again the peptic that can also lead to peptic ulcers in the duodenum. So if it is left untreated or poorly managed, they can become chronic, causing symptoms and requiring long term medical management. So that's all from my side. Now I would like to invite Yash to continue the seminar.
Good afternoon. I'm going to summarize the seminar and point down the main takeaways. During the presentation on perforated duodenal ulcerations, several key points were discussed. perforated duodenal ulcerations refers to the rupture of the ulcer in the duodenum. Here are the main takeaways. Under definition, under definition and causes, perforated duodenal ulcerations occurs when an ulcer in the duodenum develops a hole or a tear, allowing stomach acid and digestive juices to leak into the abdominal cavity. Common causes include infections with the bacteria Helicobacter pylori, uh, long-term use of non steroidal anti-inflammatory drugs, and excessive alcohol consumption. Symptoms and diagnosis. So, the presentation covered the typical symptoms associated with duodenal prolonged duodenal ulceration, such as perforated duodenal ulcerations, such as sudden and severe abdominal pain, abdominal tenderness, vomiting, and bloating. Diagnostic methods include physical examination, imaging, imaging tests such as X-rays and CT scans, and sometimes endoscopy. Sometimes endoscope. Sometimes endoscopy. Sorry. So under complications management, the presenter emphasized the potential complications that arise from a perforated duodenal ulceration, such as bleeding, peritonitis, peritonitis, then gastric outlet obstruction, penetration, and gastrointestinal bleeding. Prompt medical attention is crucial, and treatment usually involves surgical intervention to repair the perforations and remove any damaged tissue. Antibiotics and medications to reduce stomach acid production may also be prescribed. So, under prognosis and prevention, the presentation touched upon the prognosis for uh, individuals with perforated duodenal ulcerations, highlighting that early detection and treatment improves outcome. It was emphasized that preventing duodenal ulcers can be achieved by avoiding risk factors like smoking, excessive alcohol intake, prolonged use of NSAIDs, uh, yeah, treating underlying conditions like H. pylori infections can also reduce the risk. Overall, the presentation provided valuable insights into the causes, symptoms, diagnosis, management, and prevention of the perforated duodenal ulcerations. Thank you. So finally, I would like to finally, I would like to thank our Honorable HOD sir, YGB sir, and Kavita ma'am, and Shobha ma'am, and Snehal ma'am for letting us take this seminar. And thank you. We learned a lot. Yes, sir. Yes, sir. Thank you, sir. Thank you.
Ma'am, should I end it? Should I end the meeting?
Ma'am, should I end the meeting? Yes. Thank you, ma'am.
Who's talking?
Recording.